because that's the small screen. I can go anytime.
All right, I'll let you start.
Okay. Okay, let me show you this case first. So this is a nice demonstration of some classic science. So let me give you a moment to look at that image. I don't know the detailed history, but suffice it to say, a reasonable history likely is chest pain and shortness of breath. And take a look at that for a little bit, a moment, and then I'll show you the nice CT correlation. So I'm going to try to make sure that I can increase the window width, because one of the findings is relatively subtle. I'm going to try and bring it out. So the findings are, probably the big finding is this, is one. The other finding, and I hope you can see it on your screens, is that a combination. The vessels in the right upper lobe are small in caliber compared to the left side. And what I can appreciate in my screen is that this right upper lobe is more transradiant, more loosened than the left upper lobe. Additional findings are the azygos vein and the SVC are distended. So certainly with this complex of findings in that history, one should think of pulmonary embolism. So correct me if I'm wrong, but this is the oligemia, small vessels of the Westermarck sign. This, the distended pulmonary arteries, is, if it was right over there, would be the Fleischner sign, but certainly this involves the proximal descending right pulmonary artery, so it should be the Palla sign. And then, of course, because of right atrial hypertension and a big pulmonary embolism, the distended SVC and azygos vein reflect that very nicely. So yes, indeed, this patient has very substantial pulmonary embolism. With those findings, some pleural fluid, large emboli, and as one would expect, findings of right ventricular pressure overload with an enlarged right ventricle and right atrium. And this image here that I made from the CT will nicely demonstrate the difference in color between the vessels in the right upper lobe and the left upper lobe, the relative transradiancy or oligemia that goes along with that. So super typical classic signs of PE on chest radiography and corresponding findings on CT. Don't see that very often, but this is a very, very nice example of it. All right, let me show you another one. This is really just kind of a fun case for anatomy. So I'll show you this image. There's no particular diagnosis to make on the radiographs, but I want to bring up the lateral, and I'm going to bring that up itself just for a moment. And then I'll show you a follow-up exam. So typically when I'm teaching residents, I might often ask them about something to do with anatomy. And for those of you that are looking, if I said, for example, that I think there's some calcifications here, and if so, where are they located? The calcifications right there, like here particularly, and I'm less sure about this one, but this one right there would be a great location for atheromatous calcifications in relation to origins of brachiocephalic arteries, in particular, typically going from front to back, innominate artery, and then carotid, and then left subclavian. So this is the finding of interest. So I'll just leave that up by itself for a moment and show you that on the basis of angiography that was done, not on the basis of the radiograph, but because the patient has substantial symptoms of arterial ischemia, you'll see that what's interesting about this angio is that we have a very narrowed innominate artery. There's actually an origin of the left carotid right there, so this is kind of a bovine anatomy. But that calcification right there is sitting right here at the origin of those vessels. So undoubtedly there is luminal stenosis of those vessels from that big calcification sitting right there. So just a nice example of anatomy on the lateral projection and where the calcifications are located. So let me show you another one. This one too is interesting. So frontal projection of the chest will look like that. And then I'm going to show you the frontal and lateral projection from a scout tomogram from a CT. So let me bring those up like that and then mag them up a little bit. So we have opacity, and it is located in the lingular division of the left upper lobe, mostly in the superior portion of the lingular division on the two projections. And the etiology of that opacity is an obstructive phenomenon. So I'll bring up the CT, in which we have a relatively unusual situation where we have an obstructing lesion, but it spares left upper lobe bronchus, but really just gets lingular bronchus. So here we have the spared upper lobe bronchus, but here we have the opacity in lingular, and this bronchus is obstructed right there. And this turns out to be, on bronchoscopy and biopsy, a small cell carcinoma located there. So a nice example of obstructive lingular process, sparing the other segments of the left upper lobe from a small cell carcinoma of lung, as it turned out. I'll just show you that there. Here's a lesion there, and here it is on the lateral projection. There. Okay, Jeff, let me stop there. I have some others, but those are my three so far.
Okay. David, would you like to go next? Travis asked to go later.
I need a little time to cue things up here. Can you go ahead?
Yeah, I can go. Well, I have a perfect companion case for Howard's. Let me bring this one up and then show my screen here. Hold on just a second. All right, do you guys see my screen, a CT?
Good.
Okay, well, here, I'm going to show the radiograph. So this is a patient with a cough, younger patient, and we can see there's this opacity in the left upper hemithorax. The left heart border is preserved. We see most of the descending aorta. We lose a little bit of the arch, the top of the arch, and it goes up against the mediastinum. On the lateral, we see that the opacity is confined to the apical portion of the lung, but you'll see the left pulmonary artery is not in its usual location. If we go back to the frontal, you'll see that indeed the hilum is elevated somewhat. The descending artery, the left lower lobe pulmonary artery, is a little higher, and don't really see the vascular anatomy as well. So here's the CT scan. So Howard showed a nice example of lingular obstructive collapse. This is left upper lobe collapse with lingular sparing. So this was a carcinoid, this little guy sitting right here. And it was presumably causing some sort of ball valve phenomenon, but just at the right angle so that the at least the apical segment here is gone, but the lingula was preserved there. So in contrast to a typical left upper lobe collapse where you lose the left heart bore interface and you often get that lucency around it, you don't see it in this case.
Very nice.
All right. Now, this is an interesting case. This is the one I sent some of you guys this morning. This was a second opinion case. This is a 40-pack-year middle-aged man, smoker, who was billed as having Langerhans cell histiocytosis on the basis of this chest CT. And you can see as we go down, the lungs are very abnormal. So there's a couple of findings to talk about. So in the upper lungs, we see these holes. Now, some of them may have walls, but a lot of them look like emphysema or these cystic spaces, a lot along the periphery. They're not really evenly distributed. Also, the overall global attenuation of the lungs is too high. There are some smudgy nodules. So, and then as we go down, we can see again, there's this dense lung and these funny cystic spaces. Some maybe have walls, but a lot of it does not, dependent on atelectasis. And even further down, there's a similar finding in the right lower lobe with the cyst, ground glass there. So in a smoker, and as Travis had responded to me, this is, I bundle this all together sort of as smoking related diffuse lung disease. We clearly have emphysema, whether there's some RB/DIP, whatever you want to call it, but macrophages around the airways and beyond, I think we could probably state that. There's probably some fibrosis, well known in smokers, accounting for some of the distortion, some of the ground glass, and overall increased density. And there may be a few cysts that are related to Langerhans, but I don't like it for true PLCH. I'd like to see more even distribution of the holes, not just on the periphery, but more central in the lung, and a little bit more, maybe some nodules in the background. But so, and then Travis kindly sent this paper. Let's see if it's going to pull it up here. There we go. So this paper from the European Journal of Radiology, and here's just a gross specimen showing this same feature. You got these holes in the lung, and the lung's a little bit denser around it, and that's presumably a mix of it. And then similar finding where you see these funny cysts and almost looks fibrotic, but it's not honeycombing in the lungs of smokers. And in this case here, you got the larger cyst and then this big mass down there. But I think this is a good example, and that's how I've been reporting this now is smoking-related diffuse lung disease with some emphysema, and quite a very descriptive, rather than pigeonholing it in one of these diagnoses, especially when it has mixed features. Oh, my other case didn't come over yet. Okay, and then this case is kind of interesting. Let me show it here. So this is a 19-year-old woman who has had a long-standing history of juvenile chronic arthritis. And I've got CT scans going way back. So this was, let's see. All right, so, yeah, so this is back in 2000 when she was just a couple years of age. And you can see dense lungs of a young child, but she clearly had this abnormal cystic stuff and these just very abnormal looking lungs, a lot of atelectasis, but already in the lower lobes had some volume loss. And if we go and jump ahead a couple years, you can see sort of the evolution of this. So here she is 6 years after that first scan, and there's these cysts in the lung. They're defined walls, they're very perivascular. And then she has some lymphadenopathy, but again, this striking lower lobe volume loss and starting to see some distortion around the bronchovascular bundles. And then I will jump all the way ahead to her most recent scan, which is 2016. And so now we see really abnormal lungs. And what's kind of interesting is she's got what looks like emphysema. We've got some emphysema, but she's never smoked. She's a non-smoker, no marijuana, no vaping, but has these holes that look a lot like central lobular emphysema. In addition to these cysts, her lungs are diffusely dense. She's got reticulation, and then the lower lobes are really starting to look NSIP-like. We've got traction bronchiectasis, peribronchial reticulation. Her esophagus is abnormal. And then she has some septal lines down the bases as well. So when I was asked about this case, I think she's got a couple things going on. And, kids with diffuse lung disease, their scans look very strange. But considering she has effectively a connective tissue disease, I think this is sort of an NSIP-like appearance that's been long-standing and slowly progressing. I think we can ascribe the cysts to an LIP-like picture. I don't have tissue confirmation on it, but they really look LIP-like, perivascular, thin-walled, not a lot of them, somewhat heterogeneous. And then I don't know what to make of this emphysema, other than if it is emphysema, but it sure looks like central lobular emphysema, and whether that's just related to connective tissue disease or not. I don't know if anyone else has ever encountered this in a young patient who's had long-standing lung disease.
Hey, Jeff, has she been worked up for autoimmune or genetic disorders like COPA syndrome? Because that's one of those ones that we've seen quite a few cases now, and they usually present as kids with interstitial lung disease and arthritis.
I don't know the answer to that. I just know she carries a diagnosis of juvenile chronic arthritis and has been treated as such. and just transition to the adult pulmonary clinic because her PFTs are getting worse.
But yeah, I agree. Some of this is probably LIP.
Yeah,
and
I think it's a mixed picture, but I think the changes over time have been really the lower lobe volume loss, and that's mostly accounting for her progressive restrictive physiology.
And so I think we ought to worry about amyloid too with lung cysts that are basal predominant.
Yeah. As far as I know, you have a plasma cell dyscrasia, but you're right. I mean, to me, it's indistinguishable from LIP when it's just cysts.
Mm-hmm. So, Travis, what is the COPA syndrome? Please fill me in.
So COPA syndrome, COPA, is a recently recognized mutation that results in interstitial lung disease and arthritis in kids. And it was one of our pulmonologists here in his lab were one of the first groups to actually recognize it. And a few of those cases had been diagnosed presumptively as juvenile rheumatoid arthritis years ago. And then I think it was just recently recognized like 3 years ago. I can try and pull up a case or two of it, but it's one of these new ones, new mutations that they can check for.
Thank you.
The other thing that I see, which I can't explain, and it's not florid, but it's almost as if she's got maybe subpleural edema related to the fissures. And then if you scroll around, I think I may have seen septal lines.
Oh, yes, she has the fissure, and I don't know if what's going on with that, if that's related to anything, if there's just pleural fibrosis, because a lot of times they get multi-compartmental disease, and there's some pleural fibrosis that we can't see that's causing redistribution of sort of lymphatics.
Yeah, it's almost like her lungs could be a little bit wet on top of everything, and how to put it all together. Is really
this was her last CT that I was asked to look at. It's from 2016, so hard to know what's going on now. But I think we scanned her this week, and so she has a slowly progressive. Yeah.
Can you switch to my screen really quick? I pulled up one of the papers.
Absolutely.
All right, yeah, I may have to, if the phone rings here. So COPA syndrome, so Tony Schum is one of our pulmonologists here, and so we've had a few of these cases. So it's an autoimmune disorder caused by some sort of joint or mutation with lung and joint disease. And I'll just scroll straight to some of the images, and these look pretty similar to what you see here.
Mm-hmm.
Yeah, so this is over the course of time in this, I don't know if this is how many different patients, I guess this is one patient, but yeah, it's one of these things that whenever both of those in a young kid, because your patient's certainly younger than what you would expect for just run-of-the-mill connective tissue disease.
Right.
I don't know if they have any other images in here or not, but we've probably got 4 or 5 cases now here, and a lot of them have been recognized elsewhere too.
So is there a commercially available test for this mutation then?
I know all of our patients are getting tested, and I think it's tested at I want to say that like at UT Southwestern they're doing some of these genetic analyses too, but I don't know if it's clinically available yet or not. I'll look for it.
All right, well I'll let my pulmonologist know that they haven't been considered to think about it.
So yeah, I'll look while you're presenting more cases.
Okay. Here. Yeah. Well, I have one more, but I don't. It wasn't on my thumb drive, so I have to go copy it from my laptop. So I'm going to do that while one of you is showing cases. I got a really nice case. I think that you guys will like, so I want to try to grab it. So you want to go ahead and go?
Yeah. So this is an interesting case. I have not seen this in an adult of this age before, and I'll just give you a second to look at the radiograph. I think this lady is 27, as you can see. Not from the United States, so not really access to any prenatal or childhood medical care. And it's certainly an odd radiograph, and I think that one of the things that jumps out is the pulmonary arteries look pretty large. The heart's very odd configuration here, and the aortic arch looks a little weird. But I'll show you the CT. This was last year's CT. And I can't remember if anyone's shown one of these in an adult or not. You can see that the right heart, the right ventricle is enlarged and hypertrophied. And so she certainly looks like she's got pulmonary hypertension. We'd think about a shunt in somebody of this age. And here is the shunt, that she has a huge congenital AP window or aorticopulmonary window, so untreated, and now has massive shunt vascularity and pulmonary hypertension as an adult. And so this kind of accounts for why the main pulmonary artery looked so large with this large AP window. And then she also has duplicated superior vena cava, and she was injected through the left upper extremity, as you can see here. So of course, this is the rarest of the rare in terms of congenital shunt lesions, usually recognized in young kids at the time of birth. But she's an adult and she's reasonably functioning. I don't think she has Eisenmenger yet, but you can see she's got typical findings of pulmonary arterial hypertension as well, with some of these little smudgy centrilobular ground glass opacities and the corkscrew vessels that we often see in these patients. So,
wow,
just another, pretty dramatic case. And I don't know if she's had prior, she's got some volume loss in the right upper lobe, if she had prior TB or something with scar in her right upper lobe. But
So,
yeah.
Jeff, is this considered a persistence of the or a failure of the septation of the aorta from the pulmonary artery? I mean, this is an anterior connection as opposed to, say, a PDA, which is
Right.
posterior. And how close to the origin of the cava do you see this connection?
So it's a type of a conotruncal abnormality. It's isolated from a ventricular septal defect, but yeah, it is an abnormal division of the pulmonary artery in the aorta in utero. And how close to the cava? Is that what you asked, David?
How close to the origin of the aorta, the lower aorta? It seems to be the ascending aorta itself seems to be okay for a while, and then there's this connection farther up.
Yeah, and one of the studies they did subsequently was a gated CTA, so I can actually have a nice reformat that I can do for you and show you exactly what the relationship is. So you can see at the sinuses it looks fine, and it's above the sinotubular junction where this communication is. So
Okay.
right there.
Excellent.
Yeah. So this is the first one of these that I've seen in an adult, and usually they never even get CTs when they're infants because they just recognize this on echo and go to surgery. So just makes you wonder out there in this is patients from a third world country, just how many people survive like this. Survival of the fittest.
You mean like San Diego? Right.
All right, this is one from this morning. I'm curious, I want everybody's opinion on this along the pulmonary embolism theme. So this is a woman who just gave birth a couple days ago and then developed dyspnea postpartum, and not a diagnostic dilemma, that she's got pretty substantial pulmonary emboli bilaterally. You can see this large filling defect in her left pulmonary artery. She's got others on the right and in the left upper lobe. But what's really interesting about this, and it wasn't recognized at first overnight, but pulmonary emboli go into the left lower lobe basilar segments, but then those vessels are opacified distally. But look at the left inferior pulmonary vein, that it looks like there's more ill-defined smoke type filling here. But as you get further down, further distally into these pulmonary veins, there's no contrast in these. And if you put a Hounsfield on this region of interest, it's like 20 Hounsfield units. So I have no idea if these are, if this is slow flow and just smoke in these, or if it's actually that there could be associated thrombus, that's formed in the pulmonary veins as a result of the slow flow, or as a result of the upstream obstruction. Usually, as you guys know, I'm the first one to think that things are going to be just flow artifact, but this is so low, you almost wonder. I don't know, have you guys seen this before? Has anyone seen pulmonary vein thrombus as a consequence of pulmonary arterial embolism? She's hypercoagulable because she's postpartum. The thing that would argue against him being occluded is the fact that there's no asymmetric edema in that area. But I don't know. don't know if it's going to make a difference in the treatment, but I said if they wanted to, they could get more of a delayed phase. What do you guys think?
Our vote, Travis, here, Chris Meyer and I think it's smoke, and it's just really smoke. And because there's probably a lot of distal thrombus that you can't see, so there's just nothing even though you see contact, there's probably at the microscopic level lots of clot.
Yeah. Okay. Yeah, it was just a pretty peculiar one because it was, you know, if we had no contrast in the aorta, I would have no problem saying that. But the fact that there is a lot of downstream opacification, I still think you're right, because I mean, that's best guess, especially because the interface more proximally is just gradual. But I thought it was an interesting, you know, one. And I don't know if we'll get follow-up. Hopefully we do, but just thought I'd show that.
Interesting.
You would think if that was thrombus in the venous side, she'd be having embolic phenomena somewhere.
Right. Well, and that was why I wondered if it would actually be relevant to do a repeat study just to make sure there's not, if it would change management.
You could do a nuclear medicine scan, maybe. I don't know if that would.
Yeah, or just, I was thinking just repeat with delayed. Unfortunately, they didn't do an abdomen and pelvis CT or anything else at the time. All right, and then this one is one of those humbling radiographs, and I'll let you guys take a look. So this is a patient who's had a prior renal transplant, just some fevers and B symptoms. Anybody want to take a stab at what they see?
Start off at the right supraesophagus mediastinum, I think. Does not look normal there.
Yeah, exactly. So this was on the 24th. There was a radiograph from a week before, and you know, still plump right paratracheal region. It's an upright two view, and so you know, sometimes we get the large patient that has increased fat there. But yeah, that's a little too much. And Howard, would you? I think there's, maybe you could argue there's a little bit of mass effect on the trachea as well. I don't know. Maybe they're just a little rotated here, but the lungs look pretty good on this study. But wait till you see the CT that was subsequently done, and you'll see that in fact there is a big necrotic supraclavicular node right here. And then there's also just this huge bulky conglomerate of necrotic right paratracheal lymph nodes going down, I mean, that whole area, as you correctly said, Howard. And then check out the lungs. And this was only 2 days after that radiograph. So miliary pattern. And there was a CT from a few months ago, and no surprise, no miliary nodules. Patient does not have a history of cancer, but as I said, does have a renal transplant. And so weren't really, you know, they felt okay other than some fever and weight loss. So they weren't septic at this point, but this did turn out to be Mycobacterium tuberculosis, so lymphadenitis and miliary disease. And what's interesting, I thought it was kind of interesting in this case was the fact that the sputum and they first did the FNA of this lymph node up here, and it was positive for MTB, but the sputum was also pretty positive as well. And and without seeing like a actual more discrete area of consolidation, like we typically think of as the focus of infection, you know, you think of it just miliary as being only in the bloodstream, but I guess it's then seeping out into the airways as well, because there's not really a place where I can say clearly this is the site of airway centered infection. I don't know, what's everyone's experience with positive sputa in patients with miliary disease?
In my experience, the yield is lower, and same with bronchoscopy, but it's not zero. So
yeah,
I like your theory of it seeping out.
I guess so. Yeah, I wasn't surprised that the FNA of that lymph node was positive. I was surprised by this though, by the sputum. So we've seen now in the last week, we've seen probably last month, we've seen 4 or 5 cases of TB. This is the first miliary one, but we've seen several active airways TB.
Jeez.
All right, let me show one more here. And this is kind of an interesting case. So this is as you can see, 20-year-old, and I don't have a radiograph, but I'll show you the CT. And he presented, and he has a large anterior mediastinal mass. And this one is a little alarming because if you see just the left-sided portion, you see that there's areas of macroscopic fat here, some calcium or bone or rudimentary teeth or whatever. So it sure looks as if it's a mature teratoma. But there's two things. A, you have this over here, which is this more just infiltrative soft tissue, which looks like it's contiguous here. And then also he has a metastatic nodule in his left lower lobe, and he actually presented with brain metastases.
Gosh.
And yeah, so they biopsied this, and it was all immature elements. His AFP, his alpha fetoprotein was elevated. His beta HCG was elevated, and they did a core biopsy, and they got some sort of mixed, germ cell tumor. So the question is then, does that, and this is partly, I think, nomenclature, and partly just also, it's just a reminder that not everything that looks like a mature teratoma is. But do you guys think that this is probably then a immature teratoma that dedifferentiated into a malignant, or how would you classify this? Because I find a lot of confusion when I look through the literature as to whether mature teratomas can degenerate into a malignant germ cell tumor, or if it's only immature teratomas. But I think it seems to be the consensus is it's only immature teratomas, but I'm not sure.
So Travis, my understanding is that in males, the overwhelming majority, somewhere plus 99% of germ cell tumors are malignant. And even if I've seen cases that look so-called, quote, benign, but they'll have immature components. This one clearly has a lot of immature components.
Yeah.
And
it's gone. And
it's like when they treat some of these tumors, the immature component with chemotherapy, you'll see what's left over looks like mature teratoma.
Well, it's actually funny you said that, because about 2 hours ago, he got a restaging study, which I haven't had the chance to load yet. But this part has decreased, the lung nodules have decreased, and then this thing is entirely unchanged with the fat and the calcium. So, yeah. But yeah, it's just, I'm still a little confused on just the nomenclature and stuff. But you think, so Jeff, almost always in men that it's
yeah, in
immature.
The males, they're pretty much all malignant, whereas in females, it's the exact opposite. But I personally, we can just call it a germ cell tumor and let the pathologist do their job.
Right.
The whole thing needs to come out. I mean, when they're metastatic, Chris was telling me at Indiana, where it was like a big center for these, they would treat them, and then whatever's left behind, they would remove.
Okay.
Because you'll see, I don't know, but the ones I've seen, sometimes like you said, what so-called immature or non-benign look, I don't want to call it benign, but they get smaller. They may actually differentiate mature, and you're left with fat and calcium and whatever left, and then that gets removed because there's presumably microscopic rests of malignant cells in there.
Yeah.
But, I mean, these just come out.
Right. And it's just that, I thought it was an interesting case, at least for discussion, just because we usually think of teratomas as having a better prognosis, but then you have this portion, which was clearly the bad actor.
They'll have good prognosis.
Hopefully.
Yeah. So. I think you have to remove everything, though, but he has brain mets, so I don't know the answer to that question.
Yeah, because I was seeing, there was some literature that when you have more, because that's the other thing, you can have immature teratomas without malignant degeneration too, is my understanding, but I don't know. There's a lot of confusing classification.
Yeah, I think it's and they're so rare, it's hard to know.
Yeah.
Was this a mediastinal primary?
It looks like it.
Okay.
Yeah, I think so. I think here you can argue that there's probably,
if he had a testicular primary or something.
No, this was primary to the mediastinum. Yeah, not as opposed to like lung or anything. No, he had no testicular abnormality. So. Okay, well, those are mine for now.
All righty. I quickly can show my other case. I've got it loaded up now. You guys will like this one. Let me just grab it real quick.
Okay, I'll call you right back. Thanks.
All right. So last time I showed a case of fibrosing stenitis that was a little odd. My colleague Daniela alerted me to this case. So this is another young patient with really nice smoke artifacts. So Travis, you'll like this. And this is the result of a fibrosing not even really highlighted. It's sort of below that. It's affecting the lower lobe, but you can see there's this calcified blob here in the left lower lobe. The inferior pulmonary vein is gone. And actually, I think maybe it is a highlightus because I don't even see a superior pulmonary vein. But you see all this soft tissue and just a little bit of smoke, or white smoke, I guess, getting through. Unfortunately, I don't have a VQ scan on this patient. This is an outside scan, but you can see the left lung is small. There's some septal thickening ground glass, so there's probably there's venal lymphatic obstruction, small effusion, and even the airways are a little bit compromised because of this. So it's a variant of fibrosing mediastinitis. It's a little bit better in that it doesn't get centrally involved, so you don't worry about the cava or things like that. But it is effectively causing a physiologic pneumonectomy. So there's very little flow in and there's no flow out, and even the airways are a little bad. It's presumably from histo as well.
Wow. If you look at I'm just curious, if you look at the pleural surfaces, which may be thickened, do we see any dots there to suggest that systemic wall vessels are trying to come in there and help out with the lung?
Yeah.
Hard to say.
Transpleural collaterals, you can probably see a few going up there.
Oh, there are little dots there, yeah. So one could speculate that's what they are, transpleural collaterals.
Yeah. And there's the original histo lesion right down here. So what happens is just a small number of patients, they get histoplasmosis, and this would have been the lymph node draining that left lower lobe, but for somehow they mount an immune response to some of the antigens. The bug is probably long gone, and it causes this progressive fibrosis around usually the lymph node. And you can see there's little tissue in here probably. So this fibrosis just takes everything out with it. The veins go first, then the arteries and the airway typically. You get edema in the airway wall because the lymphatics are obstructed, and there's not a lot to do. Some patients may benefit from rituximab to try to at least halt any progression, but surgical intervention, short of putting a stent in here or there, is usually fraught with lots of badness. But I like the smoke in particular. I thought it was pretty nice in this case.
Yeah, very impressive.
Okay.
Jeff, I'm ready to go if you've got time.
Absolutely.
So we should be examining a Renkinogram. Is this a true statement? All right, this woman has a long history of Mycobacterium avium infection. Actually, it was Mycobacterium. Hers was speciated to intracellulare. Here, I'm going to hang this phone up here. And so she's got this patchy lung consolidation. This is an original lesion which she's had since the 90s. When they first detected this organism. She'd been treated for breast cancer. She's currently 59 years old, so she acquired this mycobacterial infection at a fairly young age. And I think it was probably it might have been an association with some immune deficiency from her chemotherapy. She had radiation and chemo. So she might have been lymphopenic for a while. Maybe that's what set things up. So now she has this patchy lung consolidation. It's spread down toward the bases. This is an amazingly persistent phone call here. Okay, so let me show you what CT looks like in her. And we have the original lesion here, which is scarred and calcified in this location. She has a little cavitation associated with that here, dilation of the bronchus, or focal bronchiectasis possibly. And then she has subsequently over the years gotten more and more lesions gravitationally dependent from that. And her big lesion here is in the left lower lobe with this thick-walled cavity. This has been there for years. It started out as a more solid nodule. And now we have cavitation. And so this is a long smoldering course of atypical mycobacterial infection. There's no known immune deficiency at this point. She does have some radiation scar up here from the tangential conforming radiation that she got for her breast cancer, but I don't think that there was, say, bronchiectasis in this location to be a setup for her acquiring the mycobacterial disease. So I'm positing that maybe she had some minor immune deficiency that set this up. And then once it's in place, it continues on its own, even if her immune deficiency was rectified. Okay, so intracellularly. And then we have this person with rheumatoid arthritis who presented, I think this is June, with patchy lung consolidation. There's not a lot of arthropathy at this point. I still have to get the history on this case, so I'm not quite up on it. And here's what this initial CT scan from outside looked like. This is this very peripheral, patchy ground glass and denser consolidation. Just loving the periphery here, the edges of the lung, and almost certainly organizing pneumonia, just given its morphology here on CT. I don't have any biopsy results of this. And this person now has rapidly progressive interstitial lung disease. So current CT looks like this. This is this month now. Just a couple of months after, we've got a lot of peripheral reticulation and ground glass abnormality everywhere. We do have I think a pleural thing here in the fissure, some abscess maybe in the fissure, or I think there was blood in this thing, and I don't know whether that came about because of a biopsy or what. But now I think we have an NSIP pattern. So in a couple of months, our organizing pneumonia pattern has evolved into NSIP. We've seen this transition before. Jeff has shown many cases where we get that transition. And this is all chalked up to rheumatoid arthritis. So I asked, in view of the rapid progression of interstitial lung disease, whether this was one of those MDA5 antigen positivity cases, a la dermatomyositis, the amyopathic dermatomyositis that presents with a rapidly progressive ILD, sometimes in advance of the myositis. And that antibody was negative. So I'll try to get the whole immune panel that's been done on this patient. So rapidly progressive lung disease, the most dramatic case I've ever seen of an organizing pneumonia pattern as the initial CT manifestation.
So
Is that just a few months?
Was
This is in the course of 2 months. So
the patient on an immune modulating drug? You may have mentioned it, but at the time, one of these new, AB, MAB, IB thingies, that this could all be drug related and not the disease itself, or was the patient not on anything for their rheumatoid arthritis?
So I'm going to have to dig out the history. But as far as I know, this was before there was any treatment. So I will rectify that if that turns out to be incorrect when I package up the case for you guys. But I think this was the presentation before there was treatment. So this is the nicest organizing pneumonia morphology that I think I've ever seen. Okay.
Yeah.
So
Wow.
and here's what the current radiograph looks like. Instead of having the patches, now we have diffuse lung disease, low lung volume, and here's that cavitary thing that had the nice fluid level on the CT scan. Okay. Now this person has some mediastinal abnormality here, some tissue that does not belong, sort of soft-looking tissue. We've got a lot of stuff here around the in the posterior mediastinum near the aorta, sort of thickening the tissue there and discoloring the fat. Things get worse down toward the bases. We've got stuff that's probably extrapleural down here. And then we get into the upper abdomen and we have these nice halos around the kidneys. And we also have some, again, we have a halo around the descending aorta here. So this is apropos of a case that Travis showed last week. This is Erdheim-Chester disease. And this is outside imaging. The person transferred care to UW. So we got some of the radiographs. There were also, by report, abnormal tibias, fibulas, and femurs with sclerosis, and MRI showing infiltration of something inflammatory in the marrow down there. Not a lot of lung disease here. It all seems to be sort of around the lungs. And let me show you more of the abdomen here, because there was a fair amount of tissue here around the descending aorta and on down. So really quite a bit of tissue infiltration here. Now, there's a manifestation of Erdheim-Chester that I had not heard of before. Now, let me show you the PET scan here. So we've got activity in the brain. That's a good thing. But we've got this activity here in the orbits posteriorly behind the globes. And this is also Erdheim-Chester affecting this compartment. I was not aware, but this is evidently a reported manifestation of Erdheim-Chester. And then when we get down into the chest, the interesting thing is that some of the tissue that's clearly abnormal on CT is not active in taking up glucose. For instance, the mediastinal stuff that we saw along here is very quiescent. It's not very bright at all. And then that posterior mediastinal tissue is also, maybe taking up a little bit of stuff, but not as active as you would expect. And the stuff around the kidneys is also not that active. I think that this is just normal parenchyma here at the edges. I'm not seeing those halos lighting up particularly here. I think this is the halo, and it's not lighting up. So my presumption is that the abnormal tissue here that is not taking up the stuff is probably the fibrotic stuff. It's probably been there longest. And the active inflammatory component, the macrophages, are probably not that prominent there. It's probably mostly fibrosis. And so I don't know whether you guys have seen this sort of biphasic look to the tissue here. This is, we don't have that many, I've not seen that many PET scans in this condition. And I'm just trying to account for, we know that this is a macrophage and fibrotic response under the microscope. And I think we're probably able to distinguish what's fibrotic and what's active macrophage inflammation by the activity on PET.
Interesting. I don't know.
This is the first time I've seen a PET for Erdheim-Chester.
Yeah, so I think we get some new information on it, because it shows that not all the tissue is actively metabolic.
Yeah, because I know that attempted renal biopsy in one patient that we had, it was solid as a rock, which I think is that surrounding fibrosis, like you're saying. Mm-hmm. So yeah, the PET would be very useful then to tell you that it's more likely fibrotic and less likely an active area to biopsy.
Yeah, I think it would really help in mapping where you should biopsy. So this is a proved case, and this was one of the 50% or so that are BRAF mutation positive. And so I think therapy is underway. Had you guys seen the orbital involvement before? That was a new one for me.
Nope.
Yeah, my case last week, I showed the MR where there was a little bit of retrobulbar soft tissue, and it is a described presentation that patients can have exophthalmos.
Okay.
But it not nearly as dramatic as that one you just showed.
Cool.
Wow.
Okay, guys. Those are the ones I wanted to show.
Wow, thank you. All right, we got a few minutes left if Howard Travis has an extra case or two.
Yeah, I pulled up a couple of the COPA syndrome patients.
Excellent.
And this is a 15-month-old, and this was identified through a family. They had a family member that also had it. But Jeff, I think I was not able to look at everything you were showing in your case, but I think it looked kind of like this in the young patient, right? With just a bunch of, did start off as diffuse nodules like this? Because this was biopsied and it was more follicular bronchiolitis at this time.
There were the diffuse nodules. There was already some fibrosis and cyst. Yeah.
And now this is a 15-month-old, so has this confirmed genetic mutation. And it's related to one of these patients. I don't remember which one it is. This is a patient who has more, looks like some areas of emphysema, some cysts. This is an older patient, even maybe you could argue a little bit of honeycombing. This was from a few years ago. But this is a patient who was originally diagnosed with juvenile rheumatoid arthritis and then later was revised to this COPA syndrome once they had the mutation test available. And I don't think I have Yeah, this I have a report on this one.
I would call that NSIP.
Yeah. Yeah. So, and he also had some pulmonary hemorrhage. So this is, I can send these back out as well. So yeah, so one of our pulmonologists here, they do a bunch of genetic tests in these patients, and then they eventually identified this. And here's another one. This is a 22-year-old, and this is just much more severe. Yeah, whenever we see this in these age patients now, I've seen a couple cases of surfactant deficiency that looked similar to this. I mean, it's just a diffuse fibrosing process. But when you also have the arthritis, it's something to think about, in addition to just other regular connective tissue diseases.
Travis, so this one looks like it has a lot more of the cystic stuff in it. Was this a smoker?
No, 22-year-old.
Yeah, it looks
at
like
that time 19.
Yeah. Emphysema, just like in the case I showed when it never smoked.
Right.
So Trap
this
is Chris Meyer. So we had a couple of other connective tissue disease patients here that are in their 20s, and I like sort of scoured the literature trying to find this cystic disease described, because I haven't been able to find it in the. I assumed that it was related to follicular bronchiolitis, but I'm wondering if we ought to write something like this up, because as far as I can tell, it's not in the literature.
The pulmonologists, they're writing up their collection of these cases of COPA syndrome, and but I agree, because we've got other stuff too, like surfactant protein C deficiency and other things that can manifest similarly. So yeah, I agree. Well, I think there's a lot of less recognized genetic disorders.
Sounds like a good review article for JTI.
And I think part of the problem too is that when I read it, it was predominantly the people that were supporting it were pediatric radiologists, and the terminology that they were using was not like Fleischner terminology. They would go reticular opacity with microcystic change, you know?
Yeah, right. And we all know what that means. Yeah,
exactly.
Well, see, if you talk about follicular bronchiolitis, then you're talking about lymphocyte disease, and that, I think, increases the likelihood that of a lymphocyte, probably plasma cell connection, and maybe again some of the holes are light chain deposition or amyloid.
Yeah, we have at least one case that has a recent biopsy that we're going to try to correlate the findings with the biopsy results. So
good.
Take a look.
Cool. All right. Well, I think it's about time. Anybody has anything else real quickly? Otherwise, we'll reconvene next week.